Well, welcome everyone to the June SWFT board meeting. Delighted to see so many members of the public joining us as well. And we start off, as we often do, our board meetings with the Going the Extra Mile winners. So I'm delighted that we've got Adam and Katie with us today. So and Dawn. So we will read out their nominations. Now, first of all, what we don't normally do with the Going the Extra Mile winners is allow nominations from our partner, our supplier partner, ISS. But the nominations for the individual winner for Adam was so exceptional that we decided it was absolutely appropriate for us to consider him, but also to celebrate him. So, Adam, delighted you're with us. Adam's joining Glenn in the what we call the Holy of Holies, which is the corner office of the building, the prime office in the whole of the estate. But Adam, what I'd like to do is just read out your nomination first of all. So, the Winter 2022 Individual Going the Extra Mile Award is awarded to the ISS porter Adam Hambridge after being nominated twice from two different members of staff. Adam responded to a bleep in the emergency department and instinctively took action during an extremely sensitive incident that impacted the entire team. He provided compassion, care and comfort to both the A&E team and the affected family, going out of his way to make a difference. Despite it not being part of his job and something that was not expected of him, he responded on instinct. Even after his shift was over, he returned to A&E to check on the staff. The nominator said, Adam went above and beyond the call of duty to support both the trust and the family during this difficult time, and he certainly demonstrated the trust's values. The nominator also noted that Adam made a difference and exceeded his responsibilities as a porter for this trust. Adam, on behalf of the whole board, on behalf of everyone who works for the trust, I just want to give you a round of applause and thank you for being our Winter Going the Extra Mile winner.
So Russell, I'm just going to hand over the framed Going the Extra Mile award. I'm just absolutely delighted that Adam could join us today, because if ever there was a definition of going the extra mile, the nominations that we had for him were fantastic. So really well done.
Thank you.
There's your award.
Thank you.
And I've also given him permission that he doesn't have to stay for the rest of the board meeting, but because he is on the day off. But it's really pleased you could join us first.
Yeah, thank you.
Fantastic, Adam. And if you do want to stay, I'm sure Glenn will find a bit of his office for you to sort of just listen in. Lovely stuff. Thank you very much, Adam. And our team winner is the Community Children's Occupational Therapy team. So delighted to have Katie, Dawn, and I think other members of the team with us. So I'll just read out their nomination first. The Winter Team Going the Extra Mile Award was awarded to the Community Children's Occupational Therapy team. The team were nominated by a member of staff for being a rock through so many recent changes. The nominator said, this team have worked tirelessly to meet the demands and maintain high standards at all times. They do everything with a smile and always keep the quality of service received by children and their families at its best. The team is a family that will stand by the service and service users always. What a wonderful nomination. Katie, team, big round of applause. Thank you very, very much for all your hard work. You're thoroughly deserved winners of our Winter Going the Extra Mile team winners. Thank you. And I'd just like to make a general point, because we do have so many phenomenal staff in the trust who day in, day out deliver phenomenal service. I want to have a call out to our teams on the McGregor ward in particular, just at the moment. They're having a really tough week on McGregor ward. And I want the message to get back to them that the board is aware. We really do appreciate the phenomenal efforts you put in to help look after the children in crisis, and that our thoughts and appreciation are with you. So although they're not nominated today, I want to just give a round of applause and an enormous thanks to the McGregor team. And also, just before we get going as a board, I do want to recognise the enormous challenges members of the public are having at the moment with car parking, as all of the great stuff we're doing in terms of redeveloping the site starts to really get going. We have got some plans to change things slightly on Monday to try and improve it. I know things are very difficult, both for patients and families and staff trying to get onto the site at the moment, but everything is being done, I can assure you, to minimise the impact, get the work done as quickly as possible, and certainly by the time we get to next year, we will be in a much better place. So without further ado, and thanks to everyone who's involved, particularly Sophie and her team who are involved on the work that's going on site at the moment. Thank you very much for your hard work, because we know it's not easy. Always easy to complain about problems, and not always easy to find solutions, and not always easy to make things better. So we have some apologies for absence. We have Phil Gilbert, Gertie, Elva, thank you for joining us, Yasmin, and I think Fiona. So lovely to see you, Ellie, and Rachel, lovely to see you as well, and look forward to hearing from you a bit later. If you've got any new declarations of interest, could you please raise a digital hand? Okay, I can't see any declarations being made. The last set of minutes held on the 5th of April. Are there any points of accuracy which colleagues would like to point out? Otherwise, I'll take them as an accurate record and I will duly sign them. Can't see any hands going up, so I'll take them as an accurate record. We'll therefore go to the matters arising, which are on page 21 of our pack. And the first was on the integrated performance report, and it asked Charles to present mortality indicators at a future board workshop. I think that's been organised for next month, Charles, so thank you for that.
That's right.
Then we had a question from a public governor for Sophie to bring back information on the main entrance building work, which we've just been touching on, to a future meeting. Sophie, I know there has been some great work on wayfinding going on with Mark and others. Do you want to just quickly brief us on this?
Yeah, we absolutely accept it's very difficult at the moment to navigate our site. So this group is meeting on a regular basis, and we are working with an external company. So I'd like to think that there'll be improvements, but we can bring that back as part of our elected pod update through the quarterly capital report. It's probably the way to do it. And we're also looking at relocating the volunteers out into the car parks to help with some of that. And so we'll continue to just try to improve that for people as we work through this. And I've added just a bit of information as well in there.
Thank you, Sophie. And just for members of the public, some of the solutions we're looking at wayfinding, I think, are really exciting, and I think will make an enormous difference to members of the public on finding their way around the site. And then we had a question, Adam, to liaise with the lead risk health and safety advisor to ensure the working on the BAF covering report be amended with reference to the digital risks. That was duly done, Adam, I think, yes?
It was indeed, yes. We've altered the way we record those digital risks. Thank
you. And then on still on the BAF, the Adam, to ensure that the risk rating for the junior doctor strike be upgraded. Adam, you've done that, but anything else to update at this point?
No, it's been reviewed through our normal risk mechanisms ahead of the next strike, which is upcoming.
Okay, great. Thank you very much, Adam. And then I'll move on to, if there are no matters arising that colleagues feel I've missed. If you think there are, could you raise a digital hand? So we'll then move on to the minutes of the Foundation Board's 3 boards meeting held on the 3rd of May. For members of the public, every 3 months, we meet as a foundation group. All 3 boards meet at one meeting to allow us to do comparative performance analysis I know a number of members of the public do join us for those and find them very informative. I really would encourage members of the public to come to those as often as they're able. The next one is in the beginning of August, to give you time to put it in your diary. But the last one was on the 3rd of May. Any questions of accuracy to those minutes? Could you please raise a digital hand? Okay, I will therefore sign them. And then I think there was only one action point arising, which was regarding the Group Analytics Board to include services data. And that is ongoing work with Jane Ives of Wye Valley and Hack Khan of George Eliot. Do you feel there are any matters arising that I've missed? Again, if you could raise a digital hand. Okay, super. So keeping things going. They've put in this new bit called Chairman's Remarks, which I always find a little bit interesting, as I sort of tend to make my remarks as I go on, but that's exactly what I'll do. It is a matter of public record, however, now that Worcester Acute are going to their board tomorrow with a recommendation that they seek full membership of the foundation group. And I would expect their board to agree that. If their board do agree that, it will then come to each of the 3 boards in the foundation group, i.e. SWFT, George Eliot and Wye Valley, for those boards to approve it. And if those 3 boards approve it, it means that Glenn and I will become Chair and Chief Executive at Worcester Acute from the 1st of August. If that is their decision, and it is very much for them to make that decision, I think that in terms of the implications, sorry, could I ask everyone to go on to mute? I can see a number of people aren't on mute. If that is their decision, I think that in terms of helping the citizens of Warwickshire, I think there will be substantial benefits over time, with a little bit of pain for Glenn and I in the short term, but I think substantial benefits for the citizens of Warwickshire over time. So we will keep you briefed on that, but that's a state of play at the moment. So moving on to some items for approval. First up, the Coventry and Warwickshire Integrated Health and Care Delivery Plan, which Rachel has had the burden of working on for quite a while now, trying to herd cats from all the different bits of the integrated care system to come to a shared view. Rachel, over to you, and Hannah, nice that you can join us as well if you're on the call. Rachel.
Thank you, Russell. Thank you very much all of you for inviting us. This is just to share with the board the work, as Russell's described, on the Integrated Health and Care Delivery Plan. It was known as the 5-year forward view, which some of you may recognise, but we call it Delivery Plan because that's exactly what it is. It's a national requirement for the ICB and the partner NHS trust organisations to produce a 5-year plan. And it links to the work that was done last autumn and winter with regards to the integrated care strategy that the system pulled together. You'll be aware of that, I'm sure, as a board, which did a large piece of engagement work with our communities, our public, and all the various partners and stakeholders in the system. We touched over 1,000 people in total to get feedback with regards to what our population wanted from us over the next 5 years. And you'll remember that that plan identified 3 key strategic priorities and 9 areas of focus. And this delivery plan responds to the health and care element of those strategic priorities. It needs to sit alongside the health and wellbeing strategies. And if you think about the King's Fund model of population health, this responds to the bottom left-hand quadrant of that model, and the health and wellbeing strategies then respond to the other 3 quadrants within it. It also covers off our national requirements in terms of the NHS operational planning guidance and any other statutory duties that the ICB has to identify and deliver to. It needs to incorporate, and there's certain links within it to many other of them. There's the myriad of complex strategies that we have across the system. So it links alongside those. And the purpose of coming today was to share the plan with organisations, to receive feedback, to take any questions. As we go through May and into June, we're trying to touch as many of our partner organisations as possible. It's also on the website at the moment and the links in the paper. We will be pulling together a more public facing document which is much more accessible for the public. But yes, the purpose of coming today is to share that link with people, give people the opportunity to feedback, with a view to this being signed off in its entirety on the 21st of June by the ICB board, which obviously Glenn will be there for, and then also to then publish in line with national guidance on the 30th of June. We have mentioned in the paper the first iteration of the feedback that we've been getting, two big themes, one being around the deliverability. This is a very, very big plan when you bring it all together, even though a lot of it is national requirement. It's the first time we've put all of this into one big plan. So there has been a piece of work done to look at prioritisation, and we again would welcome feedback in terms of how it fits with your strategic directions as an organisation. The other piece is a request that we don't duplicate in terms of reporting and assurance. So there is a working group from organisations across the system pulling together the spider's web of all the groups that will feed in terms of reporting progress against this plan, which ultimately will go up to the ICB board probably on a quarterly basis. We have also had some positive feedback from NHS England, which is detailed within the paper. Yeah, that's all I really wanted to say, Russell, in terms of keeping it brief. Happy to take any questions or take any immediate feedback now.
Okay, thank you very much, Rachel. And as I said, thank you very much for your hard work in the background. So questions and perspectives. Sophie first.
Thanks. I just wanted to say what I said at management board, which is to echo what Russell said about the work, because this is so complex. I think as a positive, though, in terms of that alignment with our strategy, it's really good now that we're looking at the deliverability of it at place. So it's great to see that in the plan. I think that's been a really positive step forward within our conversations around how we'll deliver this, and absolutely echo the challenge that we all have to do around the duplication. And it was great at our system strategy meeting that we started to have that, Rachel, around actually you've got an estates group, so let's do that bit through there. And I just think by having some sensible conversations, we'll make sure it's not we're doing this anyway. But it's a really great piece of work, and it has not been an easy piece of work, so thank you.
Thank you, Sophie. Glenn, your hand went up and then down. Did Sophie come to a point?
It's what Sophie just said.
Okay. Any other questions or perspectives? I guess, Rachel, it'd just be interesting, you know, as you said, it's very broad, it's very comprehensive. There's a lot of substance and granularity in it. What's your biggest worry about what we need to overcome as a system to deliver it? What would you regard as the single biggest risk?
Oh, that's a nice question. Thank you, Russell. I guess the biggest risk is getting the focus in terms of what we need to deliver differently. So if we're going to do what we need to deliver in terms of our 4 aims, then we should be. A natural reaction is to do the things we've always done in the same way, and it's how we work as partners in a different way, like we did throughout the COVID experience. So I think we've made really good progress in doing some of that. And Sophie's comments about place are really critical to that, aren't they? So it's how we do that work as close to patients as possible and build on the current PCNs and the local neighbourhood teams that we've got. So I think that's the biggest challenge as I see it, I think, Russell, in terms of not wanting to drift back into old ways of working and continue that integration and collaboration, and to focus on the primacy of place.
That's great. Thank you, Rachel. Glenn can't keep that hand down. Glenn?
I'll keep it up this time. I completely agree with Rachel's focus there. I think obviously one of the big issues for us is the level of financial challenge that we face as a system. But obviously we've got uncertain funding environment moving forward over certainly the next 5 years. But I think whatever the funding environment is, we do need to make sure we continue to transform, but also have a framework through which we can prioritise, and this will help us to do that.
Okay, great. So Rachel, I think you're asking for board approval of this draft, subject to some final amends over the next couple of weeks, so it can go to the ICB board in the end of June. So if you're not happy to approve this, could you please raise a digital hand? Okay, Rachel, duly approved. You're very welcome to stay with us for the rest of the board if you would like. But thank you very much, and please thank all of your team who have been involved behind the scenes.
Thank you, Russell.
We then move on to the board declaration of going concern, which I always find a slightly mysterious concept for a public body. But Kim, are we a going concern?
Yes, we are a going concern, and just asking the board to formally confirm that we are, because on the basis that we are going to continue to provide services in the public sector, and therefore highly unlikely not to be a going concern.
Thank you, Kim. Richard, as chair of the audit committee, are you satisfied that we're a going concern?
The reason for this is that the advice was changed in 2021. Prior to that, the general financial advice was that you'd need to have facilities, bank facilities and funding for the next 12 months before the auditors could sign off their audit report. But they've changed it so that public bodies don't need to have that proof for 12 months of financial facilities. So that's the difference. And because we're a public body, we will be funded.
So, as chair of audit committee, you're confirming we're a going concern?
I confirm we're a going concern.
Thank you. Any questions or perspectives from colleagues? Okay, if you're not happy to approve that statement going forward, please raise a digital hand. Joy of joy, relief of reliefs. We're confident we're a going concern. Thank you, Kim, and thank you for all your hard work behind the scenes, and you too, Richard. And that segues nicely into the annual financial plan and annual capital programme for the year we're now in. Kim and I think Sophie.
Thank you, Chair. So since April 23, a number of further iterations of the financial plan have been discussed with our ICB colleagues, and the board have been updated informally. This report provides a formal update to some of those discussions so that the members of the public are also aware of the latest position. So I'm asking the board to formally note that the final plan, which still delivers a break-even position, and also note 3 items that I've listed there. One is that the system position is now presented as a break-even plan, which is a significant improvement from the previous deficit plan that was presented. The pay award, additional pay award, has been confirmed where for Agenda for Change has also been confirmed that would they be nationally funded for. But there's also a point that I just wanted to raise really for board members around market forces factor as well, around the fact that we had an increase in our market forces factors, which meant that the trusts were effectively gaining an additional amount of income. But unfortunately, this was not notified to us in time for the contract negotiations of the latest version of the plan. But further discussions will be had with the ICB colleagues for next year as a result. In terms of the capital programme, just again to confirm that we've now had confirmation of our final business as usual allocation, and we've attached a revised plan. Sophie, I know you wanted to make a comment as well.
Thanks, Kim. It was just to note for the board's attention the change that management board approved, which was to, I think when we discussed the risks associated with some of these projects, maternity theatre is one of our highest risks at the moment, and so we really wanted to commit to be able to doing that project. So as part of that, we've reduced the medical equipment allocation at the start of the year, say the start of the year in the first quarter. That being said, that's the easiest one for us to turn up as well. So we will continue to review that as we go through the year and make amendments as schemes go under and over as well.
Very clear, thank you, Kim. Any questions or perspectives to Kim or Sophie? Glenn?
Just that point that Kim's emphasised there around the market forces factor increase in the allocation. It was built into the integrated care system allocation. So there's probably just something about me formally notifying the ICS that we would expect that to be built into our plans from next year.
Just whilst we're talking about that, did we discover where I think it was 1.8 million of additional funding for us becoming a university trust?
Sorry, that's it, Russell.
Okay. Different terminology. Terminology is very confusing. Sue?
Thank you. Sophie, is the maternity theatres work still a 2-year project? It was really great visiting the unit and seeing what the refurb is doing for patients and staff in general.
So we have an option to do it over 1 or 2 years, and we've decided to try and do it over 2 years for affordability, to split over 2 capital years. I've now got the tenders back half an hour ago that show the different programmes, and what I'll be discussing with the team is the ability to bring it forward if we're able to, but we'll just do it over 2 years. Angeli, the lead for that division, and the team are aware we're looking to do that and are comfortable that it's moving forward. And the planning has been already in train for a number of months operationally to help us achieve that as well. So it will fall over 2 years. So.
Thank you. So any other questions or perspectives? So Kim, just in summary terms, if I say something that you don't feel is a fair summary, the next year is a demanding year for us. It's a demanding year in terms of the elective work we are challenging ourselves to achieve. So we need to drive productivity to be able to do that. But the advantage we've got for the year ahead is we're moving on elective work effectively to a payment by results system. So the more elective work we do, the more we get paid. The challenge in terms of the way we're paid, though, is on outpatients work, where effectively we're paid block. So if we do more than 75% of what we did in 2019, we won't get paid any more for that additional work. So we need to be canny on outpatient work to make sure that we're not doing work that we don't get paid for. And on the cost side, our big opportunity is agency costs, where last year was a very expensive year in terms of agency, which is why all of the great work that's going on in Excel and the other programs we've got going are so important to make sure we deliver our cost and productivity improvement plans. Is that a fair summary?
Yeah, just to clarify around outpatients. So we do get paid on effectively a payment by result basis for first outpatients. So it's the follow-ups that we don't. So just a clarification point there.
But it is a block beyond the 75% of follow-ups, isn't it? Yeah. Okay, team, if you're not happy to approve the annual financial plan and annual capital programme, which we've talked about a lot at workshops and confidential board, could you please raise a digital hand? Okay, duly approved. And thank you, everyone, particularly the EDs who have gone through, and the teams down the line who have gone through an awful lot of work to get that. And I think through our finance and performance meetings and the Excel programme that I mentioned earlier, I think we are, and we'll discuss it later, I think in a good starting position to achieve what is a demanding plan. So we'll move then on to performance review and assurance, and we start off with Glenn's report. Glenn, what would you like to emphasise this month?
Thank you, Russell. As you said earlier, I'm happy with my office, but at the moment there's a little bit of noise outside for the building work we referred to earlier, so apologies if that does make a bit of noise. The NHS flagpole, importantly, will be coming back onto site soon. I know there's been some concern about that from the public, so that will be there and displaying the NHS flag very, very soon. So apologies that my paper occupies quite a few pages in the board pack. There's a lot of attachments to it, but I thought they were all important. So firstly, we start with the NHS provider license. We talked about this a little while ago. An update here from Sarah on where we are with that. Even though the self-certifications are not formally required, we think it's good practice to continue to look at those, and the audit committee have agreed to take that on board. So thank you, Richard and team. The Coventry Yorkshire ICB, there's an update there on the work of the ICB. There's also the system review meeting letter, which comes back to us. In fact, we've had another one arrive today following the most recent meeting. Obviously, they tend to concentrate on areas for improvement, but there's a lot of good performance, which we'll look at in a moment in the performance report. A couple of areas of concern, and generally areas that we need to work with system partners on. A lot of the things that we can control ourselves, we're focusing on and doing, but some concerns about oncology, waiting times and access, which I think we'll touch on it again in Harkamel's report. And then also some access to oral surgery. Both of those we're working with colleagues at UHCW to try and increase consultant capacity to ensure our patients don't wait any longer than other parts of the system. Then I refer to the national approach for improvement called Impact, which was launched recently. Really pleased to see this. We had Julian Hartley attend our 3 boards meeting to talk a little bit about this. Julian was previously Chief Exec of Leeds Teaching Hospitals, now Chief Exec of NHS Providers. His site was a Virginia Mason site. But what's really interesting around the learning from improvement is that it's important to have an improvement approach, and that's underpinned by this impact approach nationally. But it doesn't matter which approach you have, as long as you've got one. And what the analysis actually has shown, it's all about the culture of the organisation, which I'll come back to in a moment. So really encouraging that if you look at what we're doing as an organisation, there's really strong alignment with this, including having an improvement board, and there will be a national improvement board formed soon. Looking at our culture, the virtual improvement conference that took place between the 15th and 19th of May was a really fine example of some of the great stuff that's going on within the organisation, but also within the other parts of the group. And that conference was an opportunity to share more of that between parties in the group. We had some external speakers. We had lots of events going on. And we also ran one of the CUSA events. So our approach to improvement is called CUSA. And we were teaching people in the background as we went through the course of that week. And this is something that I very much hope, well, I've told them that we will do next year, so I hope it will happen next year also. And then also another fantastic event. So obviously May was conference season for us. We held the Group Nursing and Midwifery Care Excellence Conference. Again, that was a group approach. An in-person event that Russell and I were delighted to be able to spend some time around, and again some really great sharing of some of the things that are happening, and a really warm feeling about further improvements to come across all 3 organisations in the group. There's then a focus on reducing outpatient waiting times. We're part of a pilot. We had a meeting last night about this with the national team. It's now being referred to as Further Faster. Main focus is on the 80% of patients who are on waiting lists that are on non-admitted pathways, but we're looking at admitted pathways as well and looking at theatre productivity. And through this programme, we'll be trying to go faster and achieve the 52-week maximum earlier than the national milestones would set. There's then the National UEC Recovery Plan. I'm involved in leading an in-hospital processes work stream, and we had a meeting over lunchtime today on that. That's taking shape, and as part of the approach, all of the systems in the country and all of the providers will be looked at in terms of their overall performance and put into tiers. with tier 1 needing intensive support, tier 2 needing less intensive. Well, I'm pleased to say we're not in any of those tiers at the moment, but we need to keep focusing on the improvements that we've been making around urgent emergency care. Association of Groups, Appendix C, has an update on the work that they've been doing over the last year. There's then the Going the Extra Mile Award winners, and then a feature on the Solihull 0 to 19 health visiting and school nursing service, which is just another example of the complexity of the organisation and the span of the organisation. That some absolutely fabulous work going on in Solihull with those teams, which is all referenced in the report. And then an update on the monthly visits from execs and non-execs to various departments. So I'm happy to take any questions on any of that also.
Glenn, just before I invite questions or perspectives, could you just give an update on Ellen Badger? And in particular, I'm conscious of the fact there's been some very misleading press reports which may have confused members of the public as to the reality of what's happening.
Yeah, we've now released the recommendations that have come from the community hospital bed review, and we were keen to do that. There's now a process where the integrated care system needs to consider how they take those recommendations forward. What we looked at there is the changing nature of the delivery of out of hospital care, particularly our discharge to assess pathways, doing as much as we can in a home first way, but also recognising that there is a small bedded element. In fact, the modelling said that we could reduce the beds further. We decided not to as a board, and we decided to retain beds at Stratford and at Leamington Spa site. And those are the two main centres of population. But the recommendation would be that we don't put beds into the new hospital at Ellen Badger. And that's simply because the numbers of people using those beds from the Shipston area are really quite small. And what we are very conscious of are the travel times associated with obviously frail older patients and their relatives needing to visit them while they're in hospital, ideally for a very short stay. So that's the recommendation we put forward, which is really good news actually, particularly for Stratford and retaining the beds there. Unfortunately, Stratford Herald newspaper published a very misleading article last week on this, which indicated the beds at Stratford were going to close. So we've asked them to correct that report. We're actually meeting with them tomorrow, with the editor and some of their senior team, to try and understand how it is they didn't understand the press release that they were given. And hopefully we can address those communications moving forward.
Thank you, Glenn. Any other questions or questions and perspectives to Glenn, please? Sophie?
Sorry, if I could just add to that as well. Mike Wells, our public governor, alerted me to something in my paper, just for clarity. In the paper, it talked about the nickel unit and the work we're doing on it, and that the long-term plan is to relocate the nickel unit. Just for clarity, that would be on the Stratford site. So that isn't, I don't want anyone misinterpreting that as well. Just thought it was important to note that as part of the minutes.
Thank you, Sophie. Any questions or perspectives to Glenn? Just two observations from me, Glenn. Firstly is I don't think it's quite easy when you're living in the hurly-burly of life and with so much going on, not to realise or stand back and appreciate how much we are focusing on improvement work. And I think all of the things in your report, all of the different things like Go Further, Go Faster, the national recognition and programmes we're getting involved in are fantastic. And the beneficiaries of all of that work will be the citizens of Warwickshire. So I think it's fantastic. I am genuinely concerned though about the oncology situation, and I know you'll touch on it, Adam. There is, I know, a real challenge in terms of recruiting sufficient oncology capacity. But I think what's important for us as a system is we don't end up in some version of a postcode lottery where, dependent on where you live, affects the speed at which your cancer service is received. Because if there's one thing we know is for patients and families getting a diagnosis of potential cancer or actual cancer is immensely emotionally distressing. So making sure we are as good as we can be on cancer services is something I can assure members of the public that we as a board take extremely seriously and behind the scenes are working very hard on. So if there are no other questions or points to Glenn, I think that segues quite nicely into the integrated performance report. And Adam, would you care to introduce this for us, please?
Thank you. Yes, I've just got a few points of summary before handing over to the detailed reports. So I think the first thing to say is during March and April, we had a significant focus on initiatives to improve flow in the hospital. We also saw the implementation of the community recovery service to aid discharge. I think the outcome of all that work was improved flow, reduced bed occupancy, and a significantly improved ED performance. In fact, we were in the top 10 nationally for ED performance in May. It's really good news and reflects the hard work of the team. I think it's important to say, obviously, this report covers April. In May, we saw a significantly increased number of attendances. In fact, we had our busiest ever days in ED over a sustained period. So the performance won't continue at quite the same level in May, but I think the work we've done did help us, and actually we didn't see a return to the performance we had earlier in the year. But ED continues to be busy. Just commenting on cancer referrals, we continue to see the impact of the high numbers, and while there was improvement in April against the March numbers, it's still an area of focus. That brings us on to the oncology issue and oncology weights, which both Glenn and Russell have already highlighted. Huckabell's talked here about the capacity constraints previously. Over the last few months, we've resolved some of the issues in aseptics pharmacy capacity that we'd seen previously through recruitment and through support from partners, which has brought chemotherapy weights back to our expected levels. However, there remains a significant issue with weights to see oncologists. The service is provided under SLA by UHCW at the moment, and we are doing a significant amount of work with UHCW and system partners to understand the capacity and demand issues and review that SLA, and Harkamel may want to reference some more of that work in her update. Moving on to some of the other areas, April saw the commencement of our new quality priorities and the work to support them. We're already seeing some really good benefits of that. So the report highlights a reduction in C. diff infections. In terms of the friends and family test, we also saw a really high number of patients who would recommend the service, and that's clearly a key indicator for us and great news. Moving on to workforce, clearly one of our major priorities and strategic pillars as part of our strategy. So it's been reassuring to see that our time to hire has continued to reduce, recognising that we're filling vacancies more quickly and more easily. Turnover and vacancy numbers have also reduced, and I think really reassuringly, an important part of our productivity, cost and productivity plans is that we've seen a reduction in agency spend, key priority for the year, and good that we started off in the right place with that. Financially, I think we've reported here before 22-23 ended with a small surplus, and obviously we've agreed the financial plan for this year, and that process has been ongoing. Month one reported a deficit, primarily due to our productivity CPIP delivery programme. However, having said that, I think there is something in the way we have profiled our productivity programs that Kim and her team are working on. We've divided them equally up over 12 months, and we know the trajectory for delivery of our schemes is not equal across the year. So actually, we will see more nuanced reports on delivery of our productivity plans here in coming months, and we don't believe there is anything to be significantly concerned about at this point. That's all I wanted to highlight in summary, but I know colleagues will have more detail they want to give on those.
Super, thank you very much, Adam. Very clear, good overview. Any questions to Adam at this stage, Glenn?
Just really quickly to pick up the point Adam made about the community recovery service, which is a really good start. Obviously, we've got winter to test us, but that service has been running for about 7 weeks. Had an update a couple of weeks ago on the numbers on that. We've been able to put every single patient, and it was 252 when I had the update, onto their domiciliary care pathway 1 package within 24 hours of that being identified, which was our performance target, which is really good news. So it's one of our big moves to support domiciliary care. So it's good to see how well that started.
Yeah, I think the it's one of the benefits. Becky's not with us today, but Becky Howe, I think, has done a great job in getting that service up and running, and that partnership role with Warwick District Council, I think, is starting to have real benefits. But colleagues, happy to move on then to, I guess it's Ellie and Charles to give us the quality and safety update. Ellie, are you going to lead off?
I'm happy to do that. Yeah, is that right, Charles? So Adam already alluded to the friends and family test. Obviously, that's a really good marker for us as to how we are doing. Just as a little update, we are changing provider, and we're changing provider next month. And we're hoping that with our new provider, we'll even get more detail and more information about what we're doing really well and what we can improve. And we'll get some nice reports to the wards as well that's friendly for public-facing displays. So that will be really helpful. We've got a bit more information detail this month about cardiac arrests in hospital, and our recent audit demonstrated us as the second best performing hospital in the participating hospitals for cardiac arrests in a ward environment, and that's reflective of a lot of the work we do in training around staff recognising deterioration of patients and acting early, and also around having early conversations about appropriate pathways of care and preferred treatments. They're the main things I'd like to highlight. Is there anything else from you, Charles?
Just add on the cardiac arrest audit that a very striking change in the numbers that we used to have the majority of cardiac arrests in patients over 75, and that is the norm, but that has actually shifted to a lower age group in actually in the context of lower numbers altogether. And I think that really does recognise an improvement in practice in actually working with patients and families to make sure their wishes are clear and taken into account, as well as the work on deteriorating patient, which is probably the biggest patient safety intervention to reduce mortality, to actually identify patients who are deteriorating and intervene before they have a cardiac arrest.
Thank you, Charles. Thank you, Ellie. Any questions or perspectives to Charles and Ellie on the quality and safety part of our integrated performance report? Okay, keep up the great work, and please thank your teams. I know behind the scenes, some of them are on the call, do great stuff for us. So we'll then move on to the performance challenges. Harkamel, you've been dealing with an awful lot more volume, an awful lot of change, trying to drive productivity and address the oncology issues. Do you want to pull out the challenges, please?
I'll pull out the challenges, but I can't not mention A&E performance, because I'm thrilled that we were able to demonstrate what the art of the possible is when all the stars align. So we had really good bed occupancy at 92%. We had a level of attendances that we could actually manage. Adam talked about our really high attendances in May. We peaked 300. That's never happened before. So I think given what happened in April, that's really provided us with a bit of an opportunity to really see in practice like what the art of the possible is, and also give people the confidence back and that reminder of what this feeling is. It's been a really challenging winter and a really challenging summer. So I wanted to take this opportunity to say thank you to the operational teams and the clinical team. Everybody working together in April and achieving that result for our patients was phenomenal. So in terms of the challenges, I'll take the rest of the report as read, but take a bit of time just to talk through the oncology challenge. So thank you, Glenn and Alan, for providing a bit of an overview on what the problem is. And essentially, the issue is the access to the first oncology appointment, and it was the access to aseptics, but we have worked through some of those issues. So in terms of what we're doing to try and address some of the challenge around the oncology capacity, that service relies completely on an SLA with UHCW. All of the consultants that come to us are employed by UHCW, with the exception of one locum oncologist that we've employed. We've had many system meetings, and I'm really grateful to Charles for all of his support in pushing a lot of this forward and really handling much more thorny conversations than I fortunately had to be part of. As of yesterday, I met with our system colleagues to go through patient by patient detail, including like their names, when they enter the pathway, exactly what's happened to them. And we were able to go through, or I was able to provide the details of 138 of our patients to ask for enhanced support in terms of what we're going to do. And of those, we identified a core number that need an urgent intervention because the waiting times are far too long. And I'm really grateful that they have taken that action. And I've seen some emails whilst we've been on this meeting to suggest that that's being pushed forward. And if not, we have the route and we have that patient level detail to escalate that further. We also have NHS England oversight of this now. So we meet with NHS England weekly to go through our cancer performance. And they took the opportunity last time to ask about, after we've updated about cancer, what the knock-on effect is to oncology. Because I think I said in this meeting before, although our cancer referral, our cancer conversion rate has gone back to what it used to be, the overall volume of referrals to the system, to the organisation, are much higher than they ever used to be. So the overall number is bigger. So even though the percentages of conversion is the same, the denominator is bigger, so the number is bigger. So our oncology services will continue to be impacted by the increase in demand, and it's really imperative that we get this right. And I did make the escalation around the equality and the equity of access to service, because I think that's a really important point, Russell, that you sort of said at the beginning, and it's really important, I think, that we don't sort of lose sight of that. So in terms of the next steps, there's a weekly meeting which senior leaders within our organisation system and UHCW will attend, and with that we will go back with our patient level information and continue with that conversation. I think the next step, certainly from my perspective, is agreement about what this service looks like moving forward. Certainly from our perspective, we know that the demand's only going to go up, and there needs to be more resource, notwithstanding the recruitment challenges, but that conversation feels really important about what that model looks like. And there will be another meeting of everybody, including the clinical leads, with the system, I think in a couple of weeks' time, I think, which is really helpful. So we have all of the channels established, and we have a really good record of the actions that we've undertaken and the support that we need. Charles, I don't know if I've missed anything.
Yeah, I was going to add, if this is distilled down to the very essence of the problem, is we have a significant and growing mismatch between demand for oncology and supply of consultant oncology sessions. And there is a lot of work going on. There's a lot of review going on. There's a lot of analysis going on. But what worries me is that there isn't a plan and a will to start actually recruiting to that gap we've identified. And that's what I'm pushing on very, very hard. There is recruitment going on for an oncologist who's left, which has just made the problem worse, but actually addressing the underlying problem. And whilst there is a shortage, it is difficult to recruit. The sooner we start, the sooner we'll finish. And I can't see any reason for delay, because I can be absolutely confident we will be not in a position where we've overmanning.
Just before I invite perspectives, I can't apologise enough to members of the public who are being affected by this unacceptable situation. Glenn?
Yeah, and just to be clear, I think following a previous board discussion, I escalated the matter to the Chief Executive of UHCW at the end of last financial year, and to ICS Chief Executive during the last 2 months. It's really good to hear that some of the things that have been happening over recent days are starting to make a difference on that.
Yeah. Action's always the key things, aren't they, rather than warm words. I want to make a couple of other points, but I'll invite others to come in. Sue?
Yes, thank you. And thank you, Glenn, for attaching the system report to your CEO report. It's good to hear about the escalation because this has been going on too long. We all agree, and it's extremely important now that we start to get movement collectively. I would just say I visited the aseptic unit, and it was great to see what colleagues there with support from UHCW and others in the system have managed to achieve. It was really heartening to see the unit working, both sides of the unit working, and they were working flat out and they did look tired. So I want to commend them for what they've achieved and thank them for their efforts. I suppose what I feel is that, as Charles said, it's going to take a while to plug the demand and gap with the supply of oncologists. So what I was pleased about in that systems letter was it said that the action is to even out oncology clinics across Warwickshire and Coventry, essentially. So I wondered, when will that happen? Because if we don't have a clear date for that from our partners or our system or NHS England support, then I'm worried that this is going to continue. So I'd like to understand what undertakings we've got about when clinics will start to be evened out.
I think at the moment, Sue, we haven't got any assurance as to the date. Have we, Harkamel?
No. So in terms of, I'm really, really pleased that you raised that, Sue, because I think that's entirely the point, isn't it? And from my perspective, we need to have an understanding of, if you're waiting, I don't know, 5 weeks at SWFT for an appointment and 1 week at UHCW, could we port over some clinics or port over some patients and offer mutual aid, and perhaps look at it in that way. And the key, I think, to move that conversation forward is a meeting between all of the chief operating officers and the chief medical officers that Charles asked for quite some time ago. I think there's now a diary in the date for next week, so that's when we'll continue to push that. In the meantime, we have been provided with a limited amount of additional clinics, which has enabled us to book more patients. So I'm very grateful for any additional capacity. But I think you're right. I think in the absence of sufficient capacity to meet all of the demand, in my opinion, it's about making sure that the equity of access is considered, and whatever that looks like. In this, it would look like moving clinics around, I would suggest. But yeah, that conversation should happen next week.
Thank you.
Back with you, Charles.
Yeah, I think it's just important that it should be said that nobody is blaming or pointing any fingers at the oncologists who are striving, to deliver this. There just isn't enough capacity, and I wouldn't want them, if they heard about this conversation, to feel that there was any criticism based on them. This is about expansion and recruitment, and actually our support for them as a team to increase the capacity, because they are doing what they can to address the current issues.
Yeah, no, I think it seems to me there are two issues. One is there's not enough capacity in the first place. Secondly, the way that capacity is being applied, in our view, is inequitable across the postcodes. So we need to make sure there's equity across postcodes. So going back to your point, Harkamel, if you are one of our patients, you don't wait longer than if you're a UHCW patient. And there's lots of evidence for that occurring at the moment, which is something that must be addressed. On the longer term issue of capacity, though, Charles, is there a debate going on? Because I know if I'm a private patient, I want to see an oncologist. I can see an oncologist within a week in the private sector. Is someone in the system, or are we encouraging the system to think about buying private sector capacity to help us address this issue before more recruitment to increase overall capacity is actually delivered?
That's not something I'm aware they've considered. The seeing the oncologist, of course, is one step in the pathway, the key. A lot of these patients will be having chemotherapy or radiotherapy immediately after seeing the oncologist, and we can provide that. So it may be logistically difficult for some patient to see the oncologist in the private sector and then get back in, but it's a good thought, and we'll certainly raise it.
Obviously, having worked in the private healthcare market, people can put barriers up to make it difficult when in reality it need not be difficult. But can you raise that, Charles? Because I'm genuinely worried about capacity across Coventry and Warwickshire on oncology. And it's going to take a long while to sort out. And in the meanwhile, our citizens aren't getting the cancer services they deserve. But secondly, the issue which is at least as important in the short term is addressing what I'll describe as the risk of a postcode lottery, which is unacceptable among system partners. But if you could, it sounds to me as though we're making some progress on the debate. Outside of the board cycle, Harkamel, can you please keep all of the board briefed with Charles so that we're all equally aware? So if we need to raise things, we can do so. I have a chair meeting with Coventry and Warwickshire colleagues next week on Thursday, I think. So if I can have a briefing before then. But secondly, Charles, if I would ask you to talk to systems colleagues about the opportunity to effectively secure some private sector capacity, because a lot of NHS oncologists do a lot of private work, which allows people who are able to pay privately to see an oncologist faster, and that's not fair. So I want us as a system to do whatever we can to address these unacceptable backlogs. But as you say, Charles, in no way is this suggesting that the oncologists who work for us and with us are not doing their absolute best endeavours. We know they are. What we need to do is to find system solutions for our citizens, which work for our citizens, but also work for our colleagues. Any other points to be made, colleagues, on these important matters? Richard?
Just going back to out of hospital and the community recovery service, I think it'd be good. I don't 100% understand it. I know what's going on, but it'd probably be good to thank the project team and understand a little bit more. So if the next couple of months we could do a board award or even a Teams call, just to understand it and know what's thank them for doing it, but also understand what their challenges are and how we can support them.
Okay, Richard, thank you. Glenn?
Yeah, I'd be happy to do that because there is more to come on that, Richard. A lot of what we've done so far has been about how we mobilise the existing capacity. There's more work to be done on volunteering and the kind of wider community support. So that will get better.
Okay, Tim, happy to move on. So I think we're on to workforce, and Elva, over to you.
Thank you. Yes, Adam mentioned one of the improvements in terms of time to hire. So I've seen a significant improvement across the board with that, but also turnover has reduced significantly last month to 12.2% against a target of 13%. So seeing us actually get below target for the first time in certainly over a year. So that's really great to see, and kind of goes to prove that all the retention work that we are doing is paying off. In addition as well, sickness is at an all-time low at the moment, certainly based on the last 2 years worth of data, and you can see within the graph within the pack that that's showing a significant special cause variation over the last 2 months.
and early signs of data for next month is showing a further reduction. So hopefully we can get close to the trust target of 3.8%.
Thank you very much, Elva. Questions or perspectives to others? Some good progress coming there, Elva. Thank you. Okie dokie. So we then move on to the money, and Kim, taking on board Adam's introduction about the current phasing of the CPIP programme. How are you seeing our start to the new year?
Yes, so thank you, Russell. So as I said, Adam's already given a brief highlight. Just want to reiterate, really, I think, in terms of the outturn for last year, you know, the fact that we delivered a small surplus and, you know, have delivered and achieved our statutory duty to break even is no small mean feat, really, for the organisation. Yes, we did meet it by delivering some non-recurrent means, but actually, you know, we did it in the context of really significant, you know, operational pressures and increasing demand. So I just wanted to formally thank really all of our colleagues really around working together to actually deliver that, because, you know, it is a successful, you know, outcome. And I suppose I felt it just got a bit lost. So I just wanted to highlight that really. And also the fact that we delivered a really ambitious capital programme. You know, we've not had a chance to really sort of talk about last year's outturn as such. So just wanted to highlight that, you know, and thank obviously Sophie and her team who worked incredibly hard to deliver that. So just put that into context. Moving on to this year, you know, in terms of key points to highlight, we have, you know, we are reporting month one a deficit position. That's in the context of the fact that, you know, the cost improvement programme is, you know, at the moment is phased on an equal 12th basis, in the, you know, which we tend to do at the beginning of the year. To encourage really, I suppose, the divisions to get early grip on their finances and to ensure that they are managing their position, but also to recognise that we do expect the cost improvement programmes to deliver towards the back end of the year. But in the context of, you know, again, it's winter in the back end of the year, early delivery really of savings, you know, is to be promoted. Sarah will go through really the work that we're doing in terms of the Excel in Everything programme, and the fact that every day, you know, we're getting more, I suppose, confidence in the schemes and getting sort of more traction. The key thing really around the focus is around delivery, you know, around the actual money, as well as meeting our quality and productivity opportunities. To ensure that we do deliver the ambitious financial plan that you've highlighted. We note that the key driver really to the financial position is around pay. You know, 70% of our expenditure is driven by pay and therefore agency spend. The key element is around managing our agency reduction programme. Month one has seen a reduction in our spend, so positive signs. But as you've already mentioned, you know, we May is you know, operation has been more challenged than April. That normally means that there's an impact really in terms of our expenditure position. So really the focus is around using our finance performance meetings to ensure that we are you know, supporting the divisions really to manage their money. But also to protect the elective activities so that we can drive through and maximise the opportunity for us to deliver on the opportunities on elective. The last thing I wanted to draw attention to is our cash position. Our cash position is about 16 million. There's a paper in the confidential session to discuss that clearly needs to be managed robustly during the year. Those are the key things I just wanted to highlight.
Very helpful. Thank you, Kim, and thank you and your team for all their hard work behind the scenes. Questions and perspectives to Kim? Richard?
Just saying what a good performance, coming the right side of break even, because the control total last year was a deficit of 3.5 million, so that's quite important. And there's quite an important discussion later on today on the cash, because we burnt through over 20 million last year, went from 41 million to 17 million cash at the end of the year. So it's quite important, especially with all the capex that's going on and the randomness of the capex compared to our funding.
Thank you, Richard. Glenn?
Yeah, just to comment on the cash position. I realise we're discussing it later in confidential, but just in this public forum. I mean, we have deliberately set about trying to use the cash that we have to improve the facilities for patients over the last few years, and as a foundation trust, actually haven't got hold of additional national funding for a lot of those things. So a lot of it's been through the cash surpluses that we've generated by being in surplus over the last decade. So it was a deliberate plan, but I agree with Kim. It's something we just need to take stock of right now.
Yeah, no, thank you, Glenn. Any other questions or perspectives to Kim? Okay, Kim, and we'll touch on the Excel work and all the great things that are going on in just a moment on the agenda. But first of all, we'll move over to the quarterly safe staffing report. Ellie.
Thank you, Russell. So this, as you say, is a quarterly paper, so I appreciate there's quite a lot of information in it. So just to highlight really that vacancy levels are quite stable now for nursing, and it is showing to see a reduction in the incidence around inadequate staffing levels. And I think this triangulates with the data that Elva presented in her paper around the fact that we're seeing improvement in our retention rates and a reduction in our sickness, alongside an enormous amount of work that the clinical, operational and recruitment teams are doing to recruit to our vacancies. So a number of our staffing risks are being downgraded with the view to close some of them now, which is excellent. Maternity is particularly a highlight. They seem to recruit to any vacancy they ever have, and they, I think at one point looked like they were fully recruited, which is amazing. And we've seen some of our other areas closing the gap, so that's quite pleasing. Staff have been really committed to this. We've had face-to-face recruitment days, so that involves people coming in on Saturdays to support those, and they've been really well received, and we've got a lot of people interested in working for the trust from that. And then, as Alva said, it's as much about our retention work stream, really. That's what we really need to keep an eye on. So we're working hard to recruit staff, but we need to retain them, and we have our clinical lead who's working on that with people and workforce. So anybody got any questions?
Thank you, Ellie. We've got the maternity team coming up in just a minute, but any other questions or perspectives to Ellie? Sue.
Hi Ellie, yeah, it's a great team result, and in a market, we're still managing to attract really well, and as you say, it's retention is absolutely key. On retention, I noticed on graph 6 it says that it's the 12 months permanent leavers, and it says that there's no specific trends in permanent leavers, and it's not for answering now, but I would have thought that really close and careful scrutiny of what those reasons might be will be really important. So just to say that whatever data is being collected is perhaps not as helpful as it could be, and just to encourage you, as it's one of our big moves, all of the executive, to continue to progress those conversations, ideally not when people leave, but before they leave, what's working, what's not working, etc., and really record in detail. Thank you.
Absolutely. I think that's slightly deceptive, because I think we do collect some of that information, and we've got various work streams about actually not just exit interviews, but we're having things like Remainers conversations and why people stay. So I think some of that is just the way the data is pulled from ESR or from the systems, but I am aware, and any of my colleagues from workforce can come in if they like to say, yeah, I think we are collecting that data and it's part of our work stream for retention.
Glenn?
Yeah, I think it's a really important point, and exit interview data would give us some more analysis on this, and maybe what Al was about to say. I mean, one of the things I was really pleased with when I saw some of the HR team at the opening of Acorn House was the Itchy Feet clinic that they talked about there, where staff can go and talk to someone if they're thinking about leaving the organisation, so we can deliver the things that they're looking for.
Yeah, no, and Alva?
Yeah, just going to mention the Itchy Feet as well, and we do collect all the data in terms of leavers, but we do also have a number of retention groups that run for any particular hotspot areas within the trust, so we can have those discussions at a much earlier stage, and there is lots of data in terms of our retention over the span of, you know, the last year and the year before, that shows that work-life balance is one of the highest reasons. But then there's lots of caveats to that, because the manager enters the termination, not the individual. It can be perceived in many different ways, and we're linking that very much to the big move as part of being a very flexible employer as well.
Thanks, Silva. Okay, team, we are running quite a long way behind after that very comprehensive discussion we had on oncology, but we'll move then, and it's great to see so many colleagues from the maternity team for the maternity governance report for Q4. I'm not sure who's going to lead on this. Is it Lorraine and then Lynn or Becky?
It's going to be me, I'm afraid. Lorraine's on annual leave, and
Okay.
Becky is also here if there's any questions.
Okay.
So thanks, Chair, and hi everybody. And just for noting, yeah, the agenda did say Q1, but we are presenting Q4 because we haven't quite completed Q1 yet. I'll take the report as read, and I'll just be really quick and just would like to give some highlights. So I hope the report has provided the assurance to the board. So in Q4, which does seem quite a long time ago now, we continued to focus on our work against the Ockenden report and compliance. And by the end of Q4, the service had been able to complete all of the actions on 6 of the immediate essential actions, and 6 more expected to be completed at the end of this quarter that we're in now, that we are well on track for, which is really good news. As always, we've continued to focus on staff wellbeing and retention, and as Ellie kindly pointed out, we're doing really well with our vacancies. We're sitting about 3% at the moment, but this is actually due to supporting secondments within our own foundation group, and also career progression within our local maternity and neonatal system. We have launched a new triage system. We did this back in January, and this supports the correct and timely assessment of women when they present to maternity services. This is evidence-based, and it improves safety and outcomes, and that's going really well. Very pleased to say that the business case to help support the appropriate and safe staffing levels in our maternity theatres was approved at the end of March, and we've been working on that for a long time, so that was a huge achievement, and we're really grateful for that. We had access to immediate funding, so we were able to support interim staffing to make sure we maintained safety straight away. We are continuing to monitor our postpartum hemorrhage rates. Even though we have started to see some decline, we are seeing a more stabilised lower rate than we have done in the 12 months. So, but we haven't, we are still deep diving. We are reviewing every single case to see if we can get that down to where we should be against the national benchmark. We did see an increase in postnatal readmissions for our babies in our Q4. So what we did, we reviewed all the cases and we reintroduced a wait on day 3, and we have already seen that this has impacted and reduced the number of readmissions, which is really good, and we've sustained that decline of readmissions in April and May. Our work continues with the maternity and neonatal safety improvement programme, and we've got many quality improvement projects going on that's detailed in the report. And although this report, as I said, does highlight last quarter, I can't really not mention the CQC visit that we had in early April, as we'd been waiting for that, and it was noted in every report that we've done since September. The high-level feedback on the day was mainly positive, but this will be covered more in our next quarterly update. And we also, a week later, that saw an Ockenden insight visit from the regional team, and those details will also be shared in the next quarterly report. Many thanks. If there's any questions, I'm happy to take them, and I know Becky would be as well.
Thanks, Lynn. And Becky, thanks for the enormous amount of hard work you put in day out in terms of the governance side. And I'd just like to have a call out for Sarah Moppet, who, while she was interim director of nursing, did a fantastic job helping the maternity team make some of the investments that are now bearing fruit. Any questions or perspectives to Lynn? Keep up the great work, guys. Look forward to seeing what the CQC results are. For members of the public who may not be aware, both myself and David Spraggart are maternity safety champions. So we do spend quite a lot of time with Lynn and Becky, and we can really see on the shop floor, so to speak, the great work that we do. We'll move on then to the patient experience annual report. Ellie, anything you particularly like to highlight? Otherwise, we'll take it as read.
Yeah, that's fine. You can take it as read. Thank you. Any questions?
Well, Ellie, I love it. You being at the board, you get in there. Okay, exactly. Board directors.
We have all read it, I'm sure.
Absolutely, we have. Any questions or perspectives to Ellie? We're just noting this, I think, aren't we, Sarah? We don't have to approve it.
That's right, Russell.
Okay, great. Thanks, Ellie. And then we'll move on to the Excel in Everything programme. So again, for members of the public, this is a new initiative that we've set up under Sarah's leadership to pull together the strands to ensure we actually do deliver the level of improvement we think we're capable of. So Sarah, what would you like to emphasise for us?
Thanks, Russell. So yes, we launched the Excel in Everything programme at the beginning of April, so month 1 this year, and the programme does pull together trust-wide improvements in quality, productivity, and also operational delivery. So hence its name, Excel in Everything. So we've heard already in the meeting quite a few times that as we recover fully from the pandemic, there's an awful lot we need to achieve, and there's also a very finite envelope of money in which we need to do that. So the challenge is for the Excel programme is very clear, but I think it's also incredibly exciting. So if I just draw your attention to the infographic on page 1 of the board papers, hopefully that infographic illustrates how our 8 Excel work streams are aligned to support the delivery of our 5 strategic big moves and the overall trust strategy. So each work stream is led by a programme director, and each of the exec team is very kindly sponsoring one work stream. So the Excel programme is very much championed by the entire exec team. It's something that we are all living and breathing together, because it's a framework which will help us deliver the improvements that we've been talking about throughout the meeting. So the other point I'd just like to make is that our agency and locum reduction programmes, again, that we've heard about earlier on in the meeting, underpin the whole programme because they're really key enablers to help us to reduce our run rate and therefore improve our cost base. So I'm just going to pull out a few positives, highlight a challenge, and just end with some specifics about month 1, if I may. So overall programme positives, we are finding that the Excel in Everything programme is a fabulous way of engaging our teams across the hospital in our collective efforts to meet our challenges. Our approach is very bottom up. It builds on our existing improvement approach, and it's also helping us to cast our curiosity net a little bit wider and strengthen the rigour with which we challenge ourselves. And as is often the way, many of the quality improvement projects that colleagues are coming up with are also supporting the productivity agenda. And the outpatient workstream example in the papers is a good example of this. The upper GI clinical teams have worked on their vetting criteria for referrals, so very clinically led, but that's meant that we're often cutting out an outpatient appointment, and that's led to facilitating direct test. It means we're meeting our faster diagnosis treatment standard, but it's also mean that we're providing a leaner service. So it's a win-win. And that's the case with a lot of the projects that we're seeing. So in terms of the greatest overall challenge, I think from my perspective, it's a real challenge in making sure that we've got the right balance of our energies on the different types of schemes to make sure that we balance delivery across quality, operational and productivity targets. In terms of specifics and at the end of month one, the innovation and the ideas are impressive and they're numerous. But as Kim's already explained in the IPR, so far we've identified only about a third of the savings that we need to make against the target we've set ourselves of 14.5 million. So there's quite a lot more work to do in terms of cost reduction schemes. I think some of that is because a lot of the schemes haven't actually been costed up yet. And I think the good news is that the schemes which we have included in that in the money pot so far are all schemes which are delivering in the right way. They've got really high staff engagement. But we have commissioned some extra pieces of work to look at further productivity and lean opportunities. So some of those are using trust experts, some of them expert advisors across the foundation group, and some externally supported pieces of work. And then just finally, the paper contains a little bit more detail of the work to date within our Excel in Support Services work stream. And I'd just like to take this opportunity to congratulate and thank the support division, because they've actually identified productivity opportunities above their financial target. And they've got a really good range of different types of projects. They've got some just do it, straightforward savings opportunities, but they've also got some quite innovative schemes that will support flow and reduction in length of stay, as well as improving staff and patient experience. So that's it from me. Happy to take any questions.
Very comprehensive, Sarah, and thank you for your leadership. Questions and perspectives, conscious of time, Adam?
Yeah, I just wanted to thank you for the approach, Sarah. I think there's some really good work going on. We're dealing with some really tricky problems. I thought it was worth highlighting the Excel in front door redesign workshop we had on Monday, looking at our urgent emergency care services. Really, I don't know how many people were there. It was about 50, 60 people there, weren't there? And we brought the whole team together, looking at those kind of ground up ideas and really embedding transformation and improvement in what we're doing. So I think that's great. There is still a bit of work to do on those trajectories, and I know you and Kim's teams are on supporting that, and I think that's what we've really got to push over the next month. But I think it's great, and it's really resounding with the organisation. So well done.
Thank you, Adam, for those kind words. Sarah, thank you for your hard work. We'll move on, colleagues, then to the 6-month update on trust performance against national guideline on learning from deaths. Charles?
Okay, as we discussed, we're going to have a presentation to the board workshop to really get into some of the detail about these indicators work, because it is a complex area. But I think that the bottom line is we were seeing a gradual rise in SHIMI, which has been very thoroughly investigated and was thought to be largely due to problems with actually documenting our depth of coding and comorbidities, and therefore the risk adjustment of the indicator. There have been some actions put in on that, and also some of the reasons for a rising HSMR. We've seen a steep fall in HSMR. It's only 1 month, so it may be too early, but it is a significant fall. And we have seen a small fall in the SHIMI, and remembering that that is a several months in the rear view mirror indicator. So we're still and always have been within statistical control limits, and we're seeing some improvement. The medical examiner for deaths work is working very well, and we were ready to go to look at all deaths, although that community deaths included, but that has been delayed nationally. And I would say the only thing really holding us back in that regard is having an appropriate IT solution to hold all of that together. And again, there's further delay in a national solution, and we're trying to progress our own in the meantime.
Charles, very clear. Thank you. Any questions or perspectives to Charles on those learnings from deaths? Okay, super. We'll move on then to the report from Council of Governors meeting held on the 11th of May, which I will take as read unless there are any questions. Okay, thank you. So we move then to the Audit Committee report for the 12th of April, including the self-assessment. Richard, we've obviously read this, but anything you'd like to highlight?
I think that we had quite a lot of internal audit reports, which we got significant assurance from. We had an audit committee meeting this morning with the external auditors, and they've confirmed that we're on track for the 20th, and we'll get the account signed off by 30th of June. So we're doing pretty well, and a lot of progress being made. Two things. One is the accounts team have done very well because they split up all the problems and been tackling those. There's not been one person having to deal with everything, and then Sue Bunn's done a fantastic job on doing the annual reports. That's done very well. And the only thing that I raised, which is an update from this morning, we've now put online the conflicts of interest and gifts onto the electronic staff records, and at the end today's meeting we had a 74% declaration on those, which is up from 60% last year. So that's another thing that's gone well.
Thank you, Richard. Any questions or perspectives to Richard on that update? Thank you. So I'll move on then to the clinical committee reports for the 12th of April and the 10th of May. David, anything you'd like to emphasise?
No, the only thing I would like to emphasise is a positive, actually. The rheumatology work on patient-initiated follow-up actually demonstrates a way that we can be more efficient at dealing with follow-up activity, and I think that was I think they got an award for it, and so I think that's probably something that is worth flagging to committee. Otherwise, I think I'm happy with reports as read.
Thank you, David. And just going back to what we discussed substantively earlier on in the meeting about the anxiety about oncology services, you'll be taking that forward at system level, yes?
I'm indeed. I thought we discussed it very thoroughly earlier, so I didn't want to highlight it again. But yes.
Thank you, David. Any questions or perspectives to David? Okay, thank you, David, and thank you for everyone on that committee for your hard work. We've then got the Joint Audit Committee and Clinical Governance Committee annual assurance statement. Richard and David, anything you want to add to this?
Not for me.
We're both assured.
Yep.
Super. Any questions or perspectives on that statement?
It's gone through both our committees, so we've looked at it and discussed it in depth.
Super, thank you. So we've then got some items for noting and information. The first is a summary of ratified policies. Adam?
I'll take it as read. 7 ratified policies over the last 2 months.
Super, thank you. Any questions on the ratified policies? Okay, back with you, Ellie. Ellie, you're earning your salary today, honestly.
I earn it every day, Chair. Just to say, so the safeguarding reports, obviously a lot of detail in there. Moira isn't with us today, so if anybody's got any comments or questions for me to take back, I'm happy to do so.
Any questions or perspectives? It's a related point, but I just want to say again, I know over the last year it's been an incredibly tough year for us having to deal with children in crisis, and in particular the pressure that's put on our paediatric teams, not least of which the McGregor ward. So I think they do deserve our enormous thanks and praise. for having to deal with situations that an acute hospital environment is not designed for. So that would be the only point I would add. But thank you. Can you please pass our thanks down to the teams, Ellie? And then we've got the Senior Information and Risk Officer annual report. Kim?
Thank you. So just to note really that there's been a change in terms of who the CIRO officer is, and that's now me with effect from April. So this is my first formal annual report to the board. A couple of things just to highlight is just to draw attention to yourselves is that the information governance team are part of services provided by Innovate Healthcare Services. So they support us in terms of our compliance, in terms of IG issues. The Data Security Protection Toolkit is an online assessment tool of which there are 113 standards, and as of today, we have met most of the standards with the exception of one, which is to do with IG training, but we're expecting to be able to declare that we've met that by the end of June, and indeed that's a focus of our finance and performance executive meetings to ensure that the training is delivered and meeting 95% of people who've been trained in IG. There's a couple of data breaches that have been reported to the Information Commissioner's Office, of which action's been taken internally and therefore no further action from the ICO, and that I have signed off or predecessor has signed off 49 data protection impact assessments. A couple of things to note is that we've implemented an electronic system now called Information, which helps process both subject access requests and also our freedom of information requests. And we're also in the process of implementation of a system called Meta Compliance, which captures the asset register management and project documentation as well. So just a couple of things just to highlight to the board there.
Thank you very much, Kim. Any questions or perspectives on the CIRO annual report? Thanks, Kim. We'll move on then to the Security Standards 6-monthly report. Harkamel.
I'm happy to take that as read. That's okay with everybody else.
Yeah. Any questions or perspectives, Harkamel, on the Security Standards 6-monthly report? Harkamel, can you, on behalf of the board, give our thanks to those members of the team who get involved in situations where they have to face up to aggression and try and de-escalate issues. It's I know for some of the individuals here it is part of their job spec, but it's not a pleasant part of their work. So could you thank them on behalf of the board? And I'd like to make a point to members of the public that it doesn't matter what the circumstances are or the emotional stress you're under. People employed by the Trust are doing their best to help you and are doing it to the best of their endeavours. It is not fair, it's not right, and we will prosecute if you are violent to any members of our staff. Thank you, Harkamel. The Health and Wellbeing report on a more positive. Elva?
Yeah, so I'll take it as read, but just to really highlight that there have been significant improvements in terms of the health and wellbeing initiatives that have been implemented. They are in the appendices for you to have a look at, and that has resulted in a positive improvement within our staff survey results as well. So that's all been very positive all around, and no doubt has fed into our reduced sickness figures as well. Happy to take any questions.
I love the Ask Bill initiative. Any questions to Elva on the Health and Wellbeing report? I would just say to members of staff, we are an organisation who want to support you during times in life which are more difficult, so please do reach out. We do have lots of mechanisms, as Elva's report illustrates, to try and help you during those times of stress, whether it's emotional, physical or financial, but please do reach out to us. Then the updated register of directors' interest, Sarah.
Thank you, Russell. So the register's been updated to reflect changes from Russell and Fiona Burton. So happy to take any questions. Thank you.
Thank you, Sarah. Any questions to Sarah? Okay, super. Thank you. So we'll then just do some board committee minutes. The audit committee of the 8th of February. Anything you'd like to add, Richard? Richard, you're on mute. You're still on mute. And you're still on mute.
System slow today, sorry. We've had an update, gave an update at the last board meeting, so the minutes can be taken as read.
Thank you very much, Richard. Any questions or perspectives to those minutes from February? Thank you. So we've then got the Clinical Governance Committee minutes of the 8th of March and the 12th of April. David, anything you wanted to add to these?
No, nothing I want to add, no.
Okay, and so we're then on to any other business from colleagues. Could you please raise a digital hand? So we move on then to questions from members of the public and governors. Sarah, I think we've had some written questions. Do you want to read them out, please?
Thank you. So we've just had the one question, which is from David G, Public Governor of East Stratford and Borders. So David's asking, whilst carbon reduction is desirable, he would welcome the board's assurance that this programme will not have a significant detrimental effect on the trust's financial situation, at least until finances improve. I think Sophie's going to start answering this question. Thank you.
Thank you, Sarah. Sophie?
Thank you. So nationally, the NHS has signed up for us to have the commitment of being net zero by 2050. And indeed, our organisation wants to be more ambitious around that. And we've discussed at board before around how important this is for us as an anchor organisation to demonstrate that commitment. That being said, if we do nothing, there will be a financial implication for us because we have to, as part of our delivery of our green plan, look at how we reduce our demand. So that's one part. That being said, everyone will be aware in their own homes that energy costs are continuing to rise. So whilst that will mitigate it to some extent, we are anticipating that a move to newer technologies will increase our ongoing costs. Kim and I have discussed this in terms of our cost improvement programmes. We'll need to look at how we mitigate that through other schemes because some of those costs will be unavoidable. But that doesn't mean we shouldn't continue to pursue our ambition around net zero by 2050, which we've had a lot of discussions here around.
But at its simplest, Sophie, and happy for Glenn or Kim to come in, at its simplest, when we are net zero, will our energy cost base be more expensive, the same, or less expensive? Glenn?
I think you're asking us to speculate on the cost of energy moving forward, Chairman. I think if you look at it today, then the conversion into some of the technology is more expensive because we move to an electricity-based backup scenario. But I think if you look at this over a 5, 10, 15-year period, then I think some of the carbon-related energy costs will start to become a lot higher. So I think you have to take a longer-term view.
Thank you, Glenn. And as you say, Sophie, we have discussed, particularly for members of staff of a younger age than myself, it is an extremely important aspect of where they decide to work, the sort of sustainability and the real focus on net zero of the organisations they want to be associated with. So I think there'll be other benefits which we've looked at as a team, but which won't be just at its simplest looking at the energy costs. Thank you for that, Sophie. Thank you, Glenn. Any other questions from members of the public? If you'd care to raise a digital hand. Okay, so I can't see any digital hands raised, so I'll draw the meeting to a close. I look forward to seeing colleagues just checking the date of the next meeting. At our next meeting, Sarah, can you remind me when our next meeting is, please?
5th of July.
Sorry, a bit slow off the mark. Yeah, 5th of July.
So I look forward to seeing everyone at the 5th of July. Our August meeting, again, is one of those 3 board meetings. I will look forward to meeting you all, hopefully, at that as well, which, as I said, is interesting. In summary, I think we started the year as well as we can reasonably expect. I'm very optimistic about the work going on in terms of laying down capital. I apologise again to members of the public for the inconvenience that's causing in the short term. I think the transformation work we're doing under Excel is exceptional, and I'm sure we'll have not just benefits this year, but will lead to us ending this year in a much stronger position. But our big problem is oncology services. And therefore the work going on that is important. Can I suggest we have a 10-minute comfort break, colleagues, and we go on to the confidential board. See you in 10 minutes. Thank you, everyone.